Hello everyone. You may wonder why would I, who gave 5 talks about the trigeminal nerve and its branches and also devoted a whole talk to each of the other cranial nerves, would not combine 3 of them into one single talk. Did I get tired and lose my enthusiasm with the topic of cranial nerves? No, not at all. The reason is that the glossopharyngeal, vagus, and spinal accessory nerves share nuclear columns in the brainstem, and in routine MR study, the cisternal segments of these nerves are seen as a single structure. As you can see here, all 3 nerves are seen as a single structure. Now, the 3 nuclear columns, the inferior salivatory nucleus, the nucleus ambiguus, and the solitary tract nucleus, which are involved with the 9th, 10th, and 11th nerve in the brainstem, as you can see. Now, here on the axial plane, you can again see the position of the nucleus ambiguus, the inferior salivatory nucleus, and the solitary tract nucleus. Now, motor fibers come from the nucleus ambiguus. Sensory fibers for pain, temperature, touch, taste, chemo, and baroreceptors go to the solitary tract nucleus, and parasympathetic fibers that come from the inferior salivatory nucleus. Now, the position of these nuclei varies a little bit for the various diagrams you see in the literature, but the main thing is that the ambiguous nucleus is the closest anteriorly, just as far as the inferior olivary nucleus. And again, I marked where these various are. Here's a patient with dysphagia. Anybody see any abnormality? Correct. As Asif says, on the right side, we see abnormal signal on the T2 and the flare image. Patient has dysphagia. And there are many other lesions, as you can see, which are some of which are enhancing. Again, this is in a position of the 3 columns. Patient had melanoma Mets, and it's this lesion here which causes patient's dysphagia, again because of the nuclear columns of 9, 10, and 11. You can see in a similar position on the opposite side. Here's another patient that has vertigo, dysphagia, and hoarseness. Again, abnormal signal, as you can see. Again, in the position of the nuclei, except the opposite side. More images of the abnormality in the medulla, also involving the lower pons. And here we can see, again, on the coronal images, the lesion enhancing. Any suggestion for diagnosis? Not a bad possibility. Somebody mentioned MS, but it was not multiple sclerosis. Again, a disease I like to show every time. Correct. As Daniel and Asif mentioned, Lyme disease, or a variation. Not Lyme. This was ADEM, acute demyelinating encephalomyelitis. Sorry, that was not Lyme. Here's a patient with vomiting, nystagmus, and left facial droop, and we can see all the abnormalities, a stroke in the lateral part of the medulla. What's the cause here? Correct. As Gino said, we have a dissection. Eric said that also. And we can see here at the section of the left vertebral artery. We can see it here on this image. So again, the symptoms. So here we're dealing with the lateral medullary syndrome, which I talked about before, also known as the Wallenberg syndrome. And again, there's a whole constellation of findings which I talked about when I talked about the brainstem. But in this case, the 9th through 11th nuclear columns are involved in the symptoms of dysphagia, hoarseness, and the gag reflex. Again, the lateral medulla, where the stroke occurred in this patient. Here's another patient. Has upper and lower extremity numbness, nausea, vomiting, and facial droop. And if we analyze where the location of the findings, we can explain most of these symptoms. First of all, here's a little bit of a increased size of the facial colliculus. So that explains why the patient has a facial droop. We can see the stroke here in the medulla, again involving the facial nucleus here, and also by its position. You remember the medial lemniscus is the sensory tract for proprioception from the body. That explains why the patient had upper and lower extremity numbness. And the nausea, vomiting was again because of the involvement of the 9 through 11 nuclear columns, as we can see here. And a common disease that we usually may see in the brainstem. Any diagnosis here? Correct. As Nate said, multiple sclerosis. We can see the lesions again in the appropriate location for 9 to 11 nerve symptoms. Again, where the salivatory, ambiguous, and solitary nuclei are. Okay, now, how do I identify the 9 through 11 nerve? Here, let's talk about a little bit of anatomy of the medulla. So here's the olive. This is where the corticospinal tract runs. This is called the pre-olivary sulcus. Here's the olive, and behind it is the retro-olivary sulcus. So the nerves come off just at the posterior edge of the retro-olivary sulcus. And again, you can see it going towards the jugular foramen. Now, again, if we look at the specimen here, we can see at least 3 fibers or separate fibers. But on routine MR, we're only going to see a single nerve. That is, the 9 through 11 is a combined nerve. So again, if we go to an anatomy, the pyramid here, pre-olivary, olive bump, and the retro-olive, and here's the nerve. Now, one of the issues is sometimes hard to identify if you're dealing with the 8th nerve, which we can see here, and the inferior cerebral peduncle, or you're dealing lower down with the medulla and the 9 through 11 they're coming off. And because they're very close together, the only way to sometimes be sure is you have to kind of follow the nerve into the internal auditory canal or into the region of the jugular foramen, and that's where you identify which nerve it is, because they're very close together. Not at all as easy to see on the anatomic specimens here, where you can see clearly where the nerve is coming off. So in practice, it may be difficult, and you have to kind of scroll carefully through the axial images. For instance, here's the 9th and through 11th, and here's the beginning of the 8th nerve, and they look very similar in position. We can also identify the 9 through 11 on the coronal T2. For instance, here's a nerve going into the jugular foramen, and we can see it on the specimen just a little bit here. Again, the jugular foramen. Again, a little bit of the nerve, and here's a large jugular vein. So again, on the coronal CT, this is the area of the jugular foramen. But remember, because the slices are very thin, you are rarely going to see such a nice view of the entire. Usually you'll get pieces of it as the slices are very thin. And of course, for every nerve, I have to show a case of superficial siderosis secondary to a prior bleed. And again, here we have the medulla, a little bit of the retroalveolar sulcus here, and this is 9 through 11 cranial nerves, obvious with superficial siderosis. We've had a few cases of this. This is an arachnoid cyst, which actually displaced the 9 through 11th nerve. See, here's the normal position, and you see behind the retroalveolar sulcus, the nerve was pushed forward as it travels towards the jugular foramen. And even on the coronal, you can see the inferior arcing of the nerve by the arachnoid cyst. Okay, what's the abnormality here? What condition is happening here? Correct? As Asif has said, and Gino, typical appearance of a irregular kind of patchy appearance of a epidermoid, and of course the classic restricted diffusion. And again, you can see the problem with these lesions. You can see 9 through 11 traveling right through the lesion. Here's the opposite normal side. So again, restricted diffusion making the diagnosis of epidermoid. Now, one of the things we have to be aware of, here's a vestibular schwannoma, a large vestibular schwannoma in the cerebellopontine angle. Sometimes the inferior part of the lesion will affect the 9 through 11th nerve. So here on the axial thin T2s, here's the tumor, and the bottom of the tumor, which I highlighted here, is kind of pushing on the nerve. You can see the nerve is kind of a little bit on a stretch and slightly displaced anteriorly. And that's because it's being affected by the inferior part of the vestibular schwannoma in the cerebellopontine angle. And of course, I've shown this before. This was a metastatic melanoma, which I showed it last week, coating the 8th nerve and also the 6th. And here it is also on the same patient, coating the 9th through 11th nerve bilaterally. So metastatic melanoma and meningeal carcinomatosis. Here's a case of non-Hodgkin's lymphoma, again involving the 9th through 11th nerve as they travel toward the jugular foramen. And this you can even see on the coronal plane. Here's again the normal nerve. Here's the pons, and here we have the 9 through 11 nerve traveling towards the jugular foramen, also showing the enhancement of the nerve in the case of non-Hodgkin's lymphoma. Okay, where's the abnormality here? And what structure is involved? Correct, as Nate and Anshu and Gino said, and Ben, the right side, and as Gino said, the region of the jugular foramen. And here's the enhancement of the lesion in the region of the jugular foramen. Let's talk about the jugular foramen. So again, we're dealing with the glossopharyngeal, the vagus, and the bulbar 11, which I'll talk about in a minute, and the spinal accessory in 11 in the jugular foramen. And also I want to talk about the nasopharyngeal carotid space. Now if we look here in this diagram, here we see the region of the jugular foramen. The anterolateral is the pars nervosa, where the 11th nerve, the 9th would go in there, and then the pars vascularis would be the 10th and 11th nerve, which go through that. However, it's not so simple to identify the jugular foramen. If we look here at the bottom of the skull from the outside, you can see it's like a little slit. It's also hard to see completely on an axial looking inside the skull. For instance, to show it better, I had to take a skull specimen and angle it from the back, and now we see the full outline of the jugular fossa with the, pars nervosa and pars vascularis. And again, on the coronal CT, we can see it over here, and here it is on the axial, but most of the time you will only get a portion of it, like you can't even, here you see part of it, here you see another part of it, but because of the thin slices, it's not easy to catch it. Now, again, we have two major venous structures in the region of the jugular foramen, the inferior petrosal sinus and the transverse sigmoid sinus also enter. And some people have done measurements of the size of the both compartments. And again, so here we have a diagram showing the pars nervosa, or it's called the anterolateral portion, where the 11th nerve would sit, and then posteriorly the large internal jugular vein, the 10th and 11th nerve. I also have the posterior meningeal artery here. Now this is a beautiful anatomic dissection specimen from 60 years ago from Battlers Atlas, showing the beautiful anatomy in this location. Basically, we're looking at the inside of the posterior fossa from the left towards the right. So this is the right temple bone here, and here we see the transverse and sigmoid sinus. So here we have a foramen magnum here, and this is the tentorial edge here. So here we have, this is the glossopharyngeal nerve going into the pars nervosa of the jugular foramen. Notice all these veins filling the region of foramen. Here we have the cluster of the vagal nerves, which will enter here. In addition, now there's what's called the spinal accessory division, which enters together with the 10th nerve. So again, the bulbar nerve roots of the 11th nerve intermingle with the roots of the 10 within the jugular foramen. So their fibers are classified together as a cranial nerve 10-11 complex. So this is part of the 11 joining now all these 10 fibers, and then we see the spinal accessory coming up, which I'll go through later. So here we have this whole region of the jugular foramen. Now again, in routine MR, you'll just see a single strand. Sometimes you may get two of the nerves separately. Sometimes you'll see it splitting up here within the jugular foramen. But most of the time you just see a single strand. Now, it took 60 years, but as usual, the Europeans are now showing the individual nerve very similar to what we see in this anatomic specimen. So here's like an oblique thin T2 3D, and we can see now this would be the 9th nerve. These are the 10th nerve fiber, and a little bit of the 11th coming here. And here, again, from Europe, showing in an axial view the individual nerves. So this is the 11th nerve, the 10th nerve, and then the 11th joining the 10th. It's even better seen here in this oblique sagittal T2. So here's the 9th, the 10th, here's the 11th joining the 10th, and we even see a little bit of the spinal accessory coming up here. So pretty amazing that we now gotten to the stage to be able to see all this detailed anatomy. Okay, now there are two other nerves that we have to be familiar in the jugular foramen: the nerve of Jacobson and the nerve of Arnold. The tympanic nerve of Jacobson is a branch of the glossopharyngeal nerve. It passes through the inferior tympanic canaliculus and supplies the mucous membrane of the middle ear, the parotid, and communicates with their lesser superficial petrosal nerve. Then we have the nerve of Arnold, which is a branch of the vagus, which supplies the skin behind the auricle and external auditory canal, and communicates with the facial nerve via the mastoid canaliculus. And we can see both these structures on CT. So here is the inferior tympanic canaliculus for the nerve of Jacobson. We can see it here, and we can see it also on this coronal plane that I found on this case, and we can also see it on the sagittal image. So this is the inferior tympanic canaliculus for the nerve of Jacobson. And this is the mastoid canaliculus for the nerve of Arnold, which joins the facial in the stylomastoid foramen, which is in this location here. Now, why is it important to know about these two nerves? This nice diagram explains the importance of these two nerves. So here's the Jacobson nerve, which is a branch of the 9th. The reason that's important is because we have the periganglia sitting right on these nerves, and these are the cause of the glomus tours or the perigangliomas. So you see the clustered on the nerve of Jacobson, a branch of the 9th. So this would be where we would get the tympanic paragangliomas. They will start on the nerve of Jacobson. The same here with the nerve of Arnold, a branch of the 10th, which travels towards the jugular fossa. And again, we have these paraganglion bodies, and that's why we'll get a jugular fossa paraganglioma. So this is the importance of these two nerves, Arnold's nerve and Jacobson's. Okay, what's bad? What's abnormal here? Correct. Everybody's saying Gino, Ben, Asif, Nate, Anshu. An enlarged jugular foramen, eroded. Same thing here. Normal right jugular foramen. This is a coronal images I found from a CTA, and look at the marked expansion and enlargement of the jugular foramen. MR, flare images showing the lesion. Note on the MRV, occlusion and no filling of the jugular vein because of the lesion sitting in the jugular foramen. Diagnosis here. Correct. As Ben mentioned, ASIF, the paraganglioma, typical, the most common tumor we would see in the region of the jugular foramen. Asif mentioned, yeah, Ben, everybody, Gino, paraganglioma. Now, why did I hide this most important image? What does it show? Part of the initial CTA. Why did I give it such a prominent position in my slide? Correct. This is the key here, as Nate said and Gino said. The extension, see, look at the normal position of the carotid artery and look how the tumor is pushing the carotid artery anteriorly. So this tumor has come out of the jugular fossa. Here's another case, another glomus, typical pepper appearance. And this was again a jugular schwannoma, very similar erosion in the region of the jugular foramen, but again, notice this massive tumor outside the region of the jugular foramen. Here it is in the upper neck. And where is this? This is the key now. We have to understand that the lower part of the jugular foramen communicates directly with the upper part of the nasopharyngeal carotid space. If we look at this nice anatomic diagram, so here I put the arrows. This is the jugular foramen, the bony jugular foramen. So here are all the nerves coming out. As soon as they come out of the jugular foramen, they are in the nasopharyngeal carotid space. You can see the carotid and the jugular vein. So if we look at this, this is a different case. This is really a schwannoma with the nerves all around it. But you can see that here's a lesion coming out of the jugular foramen. It'll drop right into the nasopharyngeal carotid space. So when we see a tumor just outside the region of the jugular foramen, it is in the nasopharyngeal carotid space, and that's very important. So again, there's communication with the inferior part of the jugular foramen and the nasopharyngeal carotid space. Now let's talk a little about these nerves. The glossopharyngeal nerve is incredibly complicated. It has all kind of branches: the tympanic branch, the Jacobson's nerve, the sensory to the middle ear, and the bony eustachian tube, the parasympathetic fibers to the parotid, through the outer ganglion, as we can see here. There's motor branches to the stylopharyngeus muscle. Then there's a sinus nerve that goes to the to the carotid sinus and the carotid body. Then there's a pharyngeal branch and for the gag reflex to the soft palate. And then there's a lingual branch, sensory and taste, from the posterior third of the tongue. So a tremendous amount of function on this small nerve, but unfortunately there's very little that we can see in neuroradiology relating to all these functions so far. So for instance, what are the symptoms you'll get if you have autolgia due to the involvement of tympanic branch, dysphagia because of the stylopharyngeus muscle involvement, tachy and bradycardia, you have hypotension, then you may have a gag reflex loss, taste loss. So these are all very important clinical signs, but we really cannot see anything. Another thing is an isolated ninth nerve injury is extremely rare. It's always almost injured together with the 10th, and many of the lesions are the same as lesions of the proximal 10th nerve that is in the upper nasopharynx or in the jugular foramen. However, there's one thing that we can see, and that is, again, a vascular conflict between the 9th nerve and the vessel, in this case, the pica branch, which is impinging on the nerve. And glossopharyngeal neuralgia is extremely painful and was very debilitating symptoms. So again, like trigeminal neuralgia, hemifacial spasm, you can get these rare cases of glossopharyngeal neuralgia. And our only role, again, in this very complex nerve is to try to identify the possibility of a vascular conflict between a vessel, most commonly the pica, and the glossopharyngeal nerve as it goes in. Although we don't know that that's what it is, but we have to assume because of the patient's symptoms that that's the involvement mainly of that nerve. Here's another patient, had severe headache, dizziness when he was coughing or straining when he was going to the bathroom. And again, we see a pica branch here, definitely indenting the 9th through 11th, most likely, again, the symptoms related to the 9th nerve involvement. Again, here we see the normal, and there's distortion and a lot of abnormality on this side with stretching of the nerve. Okay, so now let's talk about the vagus. To remind you that the bulbar 11 contributes a fascicle to the vagus, and that's the motor innervation to the pharyngeal plexus. Now, when we talk about proximal vagus, we're talking about the vagus nerve going through the jugular foramen and the upper nasopharyngeal carotid space. And then there's an important branch that comes off the pharyngeal branch, which supplies the levator valli palatini, the palatopharyngeus muscle, and the palatoglossus. Then there's another branch for the constrictor muscles, the superior, middle, and inferior. So these are all, so if you have a lesion in the jugular foramen, you will have involvement basically of all the nerve, including the larynx. But you may also have, if you only have, let's say, an involvement a little more distally, you may only have a portion of the nerve involved. But so again, you may have soft palate atrophy, constrictor muscle atrophy, you may have patulous ipsilateral pharynx, paramedian vocal cord, and then the various signs I'll show later. Another thing, again, remember, if you have a lesion in the upper nasopharyngeal carotid space or in the jugular foramen, you most likely will have all the nerves involved. So the combined symptoms are usually hoarseness, aspiration, uvular deviation, and absent gag reflex. So it depends if you have combined or separate, and I'll show later some cases. Okay, this patient had a total parotidectomy for CA. What are the abnormalities here? What are the arrows pointing to? This arrow and that arrow. Correct. It's Asif, Anshu, Fatoperi. That's very good. But what structures involved? Fat we can all recognize. What structures are involved? Correct. As Nate said, and Matt, these denervation atrophy or fatty. This is the soft palate. Remember, supplied by the 10th nerve, and this is atrophy of the superior constrictor. Again, denervation atrophy of the superior constrictor muscle, which supplies the wall here. So we have to be able to identify the structures. So again, because of the involvement of the pharyngeal branch, we have involvement of the levator veli palatini and the superior constrictor in this case. Here's another example of acute denervation atrophy. This patient had a jugular paraganglioma, and we see all this enhancement in this region here, and this is again involvement of the superior constrictor in the nasopharynx wall. Patient had this surgery for a paraganglioma. What do we see? What is the arrowhead pointing to? Correct. There's Gino, and Nate, said, and Asif, denervation atrophy. This was actually acute or subacute. See all this bright signal here. This is actually a stir image. So this is superior constrictor involvement secondary to the surgery, and we can see acute or subacute denervation atrophy changes of the superior constrictor on this coronal image. So again, this is what's involved here, superior constrictor muscle. And here is another case showing these are chronic changes where the superior constrictor is markedly thinned. The diagnosis was not given here for why that happened, but most likely was again something in the jugular foramen or upper nasopharyngeal space. And here's a more distal, the typical expansion here, and this was the jugular paraganglioma caused denervation atrophy of the inferior constrictor, and we can see this expansion of the piriformis science region. So again, all these constrictors can be involved in a proximal vagus nerve lesion. Okay, what do we have here? Here's a glomus tumor in the jugular foramen. So we have now distal changes. We have the atrophy here. What is involved here? This, by the way, is silicone injection for the to enlarge the paralyzed vocal cord. But what is atrophic here? See, this is the normal muscle here. Which muscle is that? Well, I won't belabor because it's not something that we usually focus on. This is the cricoarytenoid muscle. It's a very small muscle, very important to the mobility of the vocal cords, but you can see again the damage, denervation atrophy of the cricoarytenoid muscle shown nicely here in Netter's atlas. So again, here we have vocal cord paralysis with all the signs. What caused this paralysis? What do we see on this image? Anshel said right carotid mass. That's almost correct. What are the findings here? Correct. As Gino said, the splaying of the vessels. There's a mass here, and we can see the separation of the carotid and the jugular vein. There's a mass. So here's the mass. So the carotid is pushed forward, the vein is compressed. This is the mass. But notice that the patient presented with laryngeal. So this is again a proximal lesion causing distal vagus changes. But this is now no longer in the jugular fossa, but in the nasopharyngeal carotid space. So remember before I showed lesions in the jugular fossa, but here we have a lesion now in the carotid space, splaying the carotid and the vein, but caused vagus nerve symptoms in this location, further down from the jugular foramen. So carotid space, in this case with a schwannoma, can also present with laryngeal because proximal vagus nerve lesions. So again, if we look at these diagrams, here on the axial, higher up in the nasopharyngeal carotid space, we see all the nerves. We'll see the 12th nerve, we will see the 9th, 10th, and 11th. But as we come down, lower down, let's say the level of the thyroid, we only will end up with the vagus nerves because the other nerves already exited the carotid space. Okay, what do we see here? Again, a classic of laryngeal paralysis on the left side. And we see here our arytenoid is pulled forward. We have the so-called Sale sign, the arytenoid pulled forward, so definitely palsy. What's the cause of this palsy? Correct. As Asif said, Gino, there's involvement. Here's the mass. So now we're talking about distal lesions of the vagus nerve. No longer up high where other nerves may be involved, but this is strictly vagus. This was a metastatic lesion from a pancreatic carcinoma. And notice its position. Why this is important is, you remember the vagus comes down, and then on the left side, the recurrent laryngeal nerve will come out and travel around the inferior surface, undersurface of the aortic arch. On the right, it goes around the subclavian artery. So, either the tumor, like in the case, involves the vagus itself or the recurrent nerve and the AE window. So again, you end up with the paramedian vocal cord, the pachus ventricle, piriform sinus, and the angulated AE fold, all due to a distal lesion, this time involving only the vagus or the recurrent laryngeal nerve. Here's another case showing palsy, the angulation of the AE, and the forward position, and the enlargement of the ventricle. And this again was due to a chest mass pressing on the aortic arch. So maybe involving here the vagus itself. I mean, definitely involving the vase itself. Okay, what's happening here? Correct. As Gino said, there's a lesion involving the recurrent laryngeal nerve, causing the palsy again. Always look at the arytenoid being pulled forward. But this mass was actually a thyroid carcinoma. Okay? So it would involve not only the recurrent nerve, but also the superior laryngeal nerve and its branches. So this was a lesion right there. And again, this patient had a thyroidectomy, and again we see the laryngeal paralysis and the denervation atrophy of the cricoarytenoid. Okay, now let's talk about the spinal accessory nerve, which is motor only. It only has motor function. The interesting thing is that the spinal accessory nuclei are located in the lateral aspect of the anterior gray of the cervical cord, all the way from C1 to C5. And then the nerve fibers ascend and go up into the cranial cavity to the foramen magnum, and then they come out through the jugular foramen, and then come to supply only two muscles. So again, here's the nerve coming up, goes through the foramen magnum and into the jugular foramen, and it joins the branch that, the special branch that what's called a bulbar 11, which travels with the vagus and supplies the pharyngeal plexus. Now the two muscles innervated by the 11th nerve, the sternocleidomastoid and the trapezius. And again, you can see the fibers coming up into the cranial cavity, coming out through the jugular foramen. And pretty amazingly, I even found a case where we could see it. We're approaching the European work here. So here here's a coronal thin T2s. We can see the fibers of the 11th nerve coming up, and you can see how they're traveling now towards the region of the jugular foramen. And here's the nerve on an axial thin T2s. We can see on either side, we see the spinal accessory nerves. And of course, the Europeans again show, here's a spinal on an oblique sagittal. Here's the 11th nerve coming up towards the jugular foramen, where it joins the upper branch, and here it is again. So, and here it is on the axial, just like I showed before. Okay, so I showed this case before, jugular mass, distal lesion involving the larynx, and the denervation atrophy of the cricoarytenoid. Same patient. Why am I showing this? Correct. Asif, Nate, Gino. Let me be sure, give everybody credit. Nate, Gino, Matt, Eric, Asif. All mentioned the findings. And what are the findings? Atrophy of the sternocleidomastoid muscle. Look at the normal size, very small remnant here. Trapezius, normal trapezius, and the atrophic right trapezius. And this, what is this here? What is this large structure here? Usually it accompanies this denervation atrophy of the two muscles. It's not the scalene. Another muscle? Correct. As Nate said, the levator, and Gino said, the levator scapulae. What happens is that the levator scapulae, it kind of takes over for these atrophic. So again, this was a proximal lesion. Remember, I showed you going way back that this was the lesion in the jugular foramen. So it involved all the nerves involved the 10th and also involved the 11th nerve by affecting these muscles. So again, when we have spinal accessory nerve symptoms, you'll end up with a shoulder droop, weakness in the rotating the head. You'll have trapezius and superior sternocleidomastoid atrophy, and you have levatoscapular hypertrophy, as we can see here. Also, sometimes patients may have torticollis if you have, let's say, a cervical tumor, a cervical cord tumor. It may affect the neurons of the 11th nerve, and you'll end up that the patient will have torticollis. Okay, so that may be symptoms of a tumor. And here's the last slide I wanted to show. The same patient shows what here? Correct. As Gino said, Asif, Eric, there's atrophy of the tongue musculature here, the inner musculature of the tongue, fatty replacement. So this shows this one patient, because he had the lesion in the region of the jugular foramen, had the 10th involved, the 11th, and also the 12th. And if we look now here, which I'll talk next time, this is the 12th nerve that does not go to the jugular foramen, but goes to the hypoglossal canal, which is right next. And you can see that as the nerve goes, as soon as it comes out, it's in the nasopharyngeal carotid space. So if you have a large lesion in the region of the jugular foramen and right in the upper nasopharyngeal carotid space, it'll catch all four nerves. In this case, as far as we know, we only have 3 nerves involved. We had the 12th nerve, the 10th, and the 11th, and I showed you the various changes that affected those 3 nerves. So this is the end of my talk today. Thank you for your attention.